as well. So what if I can't attend a group program? Well, that's no problems. At Absolute Care Therapy, we also offer engaging home-based CST as well. So this is a program that's created by us, but it's actually delivered by your support team or your family. So what's offered in this program is we'll do a home review where we get to know you, we get to know what you like, what you don't like, your strengths, maybe some areas that you want to work on. And then we'll formulate a series of individualized therapy sessions, write these up into clear plans for staff to follow with lots of helpful tips along the way. And then we also provide engaging resources, coaching and support along the way. Also, the program is really good for support staff or families who are looking to learn about meaningful activities they can do with their loved one. And I also find that people who have a lot of respite hours, they have a lot of people sort of sitting at home, you know, or how to engage or what to do. They might go shopping and do activities, but then they get a bit bored. This program can be really great because it is meaningful activity, evidence-based therapy, and it can be run 2 or 3 times a week. And the sessions are about 30 minutes, so really easy to fit into a schedule. So how we run our group program, this is certainly our most popular program. At Absolute Care Therapy, we run it in very, very small groups of only 4 to 6 participants with 2 highly experienced facilitators. So I do that intentionally because I want to provide a very high level of individualized support. CST can be provided in groups that are bigger than this, 8, 10, maybe 12 participants. So really everyone runs CST differently. So I'll really be speaking to how I run it in my programs. Every session is personalized to the people attending, to what they're interested in. And how I see my role as a facilitator is to showcase your strengths and then to support areas that you might find a little bit challenging. And we don't steer away from areas that we find challenging because that's where the really good areas of neuroplasticity can occur. If we can find those things that are difficult and we can work through them and sort of work through ways of navigating around that, and that's where I think the good brain health and framework happens. So our programs can be fully funded through the NDIS and home care packages. You'd need to check with your own CST providers about that as well. So I thought I'd put some images in to try and show you what a CST session may look like. So in this session, this is a sound session. We will play a sound. We'll then ask people to try and recognize the sound. We may show some images, some pictures, and ask you to say, to let us know which image matches the sound. And so you can see just in this activity alone, we're using our auditory processing skills, we're using our thinking and memory skills, we're using our visual processing skills, and we're also using our communication skills. So we're using a whole lot of skills, a whole lot of brain activity is happening just in this one activity. Orientation skills is another activity we do. We've got a big map of Australia. We'll find some interesting landmarks around Australia and we'll hand these cards around to the people who are attending. We'll then talk about whichever cards people want to talk about. We might pop them in the related state that, the state in Australia that they relate to. We might talk about travel experiences, memories, anything that pops up really. And again, there's no right or wrong with this program. So if somebody doesn't remember the Great Barrier Reef, they want to talk about boating adventures they've had, or they want to talk about sharks or something that relates to something in the image, we go with that. And it's all about succeeding. It's all about personalizing it to make sure that you feel really good and confident during the session. And another session we do using money, this is a great one where we look at the currency, we'll look at the old Australian currency versus the new. We might look at the people, the faces on the currency. That's been a big learning curve for me because I didn't know who most of them were. We might look at the value of objects, might do a shopping trip. So all these skills are actually really functional. They relate to day-to-day activities and also really lots of fun as well. We make it really, really enjoyable. So there's 14 topics that we cover. I'm not sure how I'm going for time. 14 topics that are covered in the group program. Some of the favourite ones would be physical games. As a rehab physio, I love creating interesting, fun games. And boy, it brings out everybody's very competitive spirit. Food is another great topic. We'll look at foods around the world. We'll bring in different foods to trial. And so we get to eat a lot in that one. Everyone loves that session. And being creative is another really great session. So being creative is actually really, really good for our brain health for all of us. So that's another really enjoyable session. They're all very enjoyable. I work really hard to make these sessions very, very engaging, really fun. There's lots and lots of laughs. A lot of my participants have been complaining their cheeks hurt lately because they smile so much, but I take that as a compliment. I think a little bit of pain is okay for the game. So at its heart, CST is more than just therapy. It's about undertaking meaningful activities that help a person feel valued, feel connected, and feel confident in everyday life. I think that sums it up from my end. So if you'd like to know more about how CST can help you, or even how to start running CST in your organisation, you're welcome to book a free 15-minute consult with me on my website. And that's it. So thank you very much. I hope I've inspired some people out there to look at CST for themselves and also CST for your organisation, because we really need this program up and running around Australia.
Fantastic. Thanks, Amanda. And yeah, I wish I had known more about these programs in the early days supporting Mike, but I suppose somehow or other I think I was doing this without even realising it anyway. But thank you. And so now let's move on to Naomi. For those who have just joined in the last few minutes, please mute yourselves and turn your videos off so that for the duration of the program it would be really helpful. Thank you. So now I hand over to you, Naomi.
Thanks, Vicky. Sorry, there's some technical problems there. I'll just start to share my screen. We've got that now. Can everyone see that first slide?
I think you might want to maximise it because we can see all your notes as well.
Yeah. Is that better?
Yes, it is. Thanks, Naomi.
Right. Okay, thank you. Sorry. Okay, thanks for your great presentation, Amanda. I would also like to acknowledge any people with a living experience of dementia who are joining us today, as you are our greatest teachers in the work that we do. And thank you, Vicky, for the opportunity to join and present today, and for everyone for joining us. The COPE program stands for Care of People Living with Dementia in Their Environment. And along with the CST and SPICE programs, I'm really passionate that people living with dementia and their families should have access to these evidence-based programs following a diagnosis to provide a reablement or rehabilitation-based approach to support their wellbeing and quality of life. I've had the privilege of engaging with people living with dementia and their care partners over many years, delivering the COPE program in private practice. And in the last year, I've been working with Brightwater Care Group and developing a younger onset dementia service, which the occupational therapists have trained in the COPE program. So the COPE program is an evidence-based program and with an optional nurse component. It's designed to enhance the wellbeing of both the person with dementia and care partners. It helps the person live with dementia manage day-to-day activities and the care partner to support them to remain living well at home. So COPE is designed for people living with dementia at home and have experienced changes in their functional ability or challenges in daily life, and probably more in the mild to moderate stages of dementia. And for care partners who they are living with, who have experienced stress or challenges within their caring role. So COPE aligns with the Australian Clinical Practice Guidelines and Principles of Care for people living with dementia. And this states that people with dementia living in the community should be offered occupational therapy interventions, which should include environmental assessment and modification to aid independent functioning, prescription of assistive technology, and tailored intervention to promote independence in activities of daily living, which may involve problem solving, task simplification, and education and skills training for their carers and family. COPE was developed in the United States by Laura Gitland and has been found to be effective in a large randomised controlled trial. It was also effective when translated into the Australian context in research undertaken by Professor Lindy Clemson and Dr. Kate Labour. Results showed that people with dementia who received the program became more engaged in activities, and care partners and families reported they were better able to care for the person with dementia, with some specific examples listed here on the screen. And these slides will be shared with you all after the presentation. COPE's delivered in the person's home in up to 10 sessions. However, this can be modified and be flexible to meet the needs and funding of the participants. Assessments are done in person, and if required, some of the implementation sessions can be delivered via telephone or telehealth. The sessions cover 3 phases: the assessment, the implementation of prescriptions for 3 areas of challenge and 1 activity prescription, and finally the generalisation sessions to discuss ways to modify the activities and strategies to other areas of challenge or adapt to changes in function and cognition in the future. A nurse can be involved in the program for reviewing health needs and providing support for medication, hydration, continence, pain, and infection management. However, the nurse component is not compulsory and often not delivered in Australia with the COPE program. COPE uses a unique range of assessments which are done very casually within a person's home, including a clinical interview, an interest checklist, a falls risk assessment, social functioning, a personal profile, looking at dementia-enabling environments, functional cognition, and the disability assessment of dementia. In the sessions, the occupational therapist and care partner work together to develop 3 prescriptions to address areas that they might be finding challenging. This could include things like agitation, sleep, dressing, repetitive questioning, and then they will also develop 1 prescription to enhance engagement in a meaningful activity. The prescriptions incorporate strategies to 1, communicate effectively, 2, create enabling environments, and 3, simplify activities. Each session will also identify and practice appropriate stress management techniques for the care partner and the person living with dementia, if they would like to engage in that, as well as provide a range of resources to support the care partner, including the Caregiver's Guide to Dementia book. So these are some examples of challenge areas that might be addressed or people might be experiencing, and any sort of prescription can be tailored for the needs of the participants. The COPE principles include being client-centred, being culturally relevant, problem solving to identify strategies and activities, and using learning through active engagement. So as I mentioned at the start, traditionally we have not seen a lot of reablement or rehabilitation approaches offered to people living with dementia. The World Health Organization defines rehabilitation as a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interactions with their environment. Impairment in function is a core diagnostic feature for dementia. The benefits and rights of people living with dementia to access rehabilitation programs are now being recognised. Programs such as COPE are designed to enable people living with dementia to function optimally and reduce their disability. Occupational therapists have the skills to assess and observe factors relating to a person, their occupation or activity, and the environment. In particular, occupational therapists can assess functional cognition and how dementia impacts a person's ability to perform everyday activities. OTs can then help find a good fit between these factors and develop strategies to enable a person to engage in meaningful activities and support their well-being. So for me, some highlights of delivering the COPE program is that it is such a privilege of getting to know a person within their own home. And this provides a real opportunity to embed strategies in their home environment. It provides time to build trust and relationships. It allows collaboration, problem solving, and knowledge sharing. So we're doing with and not for people. Building skills to continue to live well following a diagnosis of dementia. It really recognises the role of the care partner and incorporates stress reduction strategies for them. And I think one of the benefits that I've really seen is that we're in a home and we can help navigate services that is often something that isn't provided to people following a diagnosis of dementia. So some interviews were conducted with COPE recipients in some research that was done on COPE in Australia. And the recipients shared some sentiments such as the program was giving them a second chance at supporting the person living with dementia, and that the person are now still participating in daily activities. And they really appreciated navigating together through the journey with the occupational therapist. So COPE can be accessed through an NDIS funding arrangement. And if you know anyone who is older, they can also access it through a home care package. You could also talk to your doctor about using a chronic disease management plan where people will get a partial rebate for a limited number of sessions. Or should you have occupational therapy within your private health cover, you could get a partial rebate for some of the sessions. So to access a COPE practitioner, you can find someone, hopefully, in your area who is delivering COPE on the COPE website that is on the screen here now. And as I mentioned before, at Brightwater, we do have occupational therapists trained in the COPE program, and there's some details there as well. If you happen to be an occupational therapist or a nurse watching today, you can access the COPE training through the COPE website once again. And I think there's some training coming up in June that's done online over 2 days. And following the training is the opportunity to join a wonderful community of practice, which is very supportive and run by Sally Day and Kate Lever, who are the COPE trainers in Australia. So if anyone has any questions about COPE, wherever you are, I'm more than happy for you to contact me, and my email is up on the screen too. Thanks very much.
Well done, Naomi, and I'm just loving that we're all sticking to time. And look, that's a lovely contrast from the CST to have an in-home program. So I'm really loving that, we've got 2 programs that are in different settings. So fabulous. So now I'm going to hand over to Nathan, and then after that we'll go to the discussion and questions. So I would invite all of you in the audience to use the chat for any questions that are arising from the subject matter being presented. Fantastic. Let's go.
Thanks, Vicky, and thanks very much for the invitation to talk about the SPICE program. So I'll just start off by talking quickly about post-diagnostic support, which is crucial for people with dementia because it helps them to understand their condition, manage symptoms, and maintain independence while also reducing anxiety and isolation after diagnosis. And this support enables people with dementia and their families to plan for the future, access necessary services, and live as well as possible with dementia. So there are a number of evidence-based interventions, and you've heard about 2 of them already today, that can support people with dementia and their care partners. So cognitive interventions such as cognitive training, cognitive rehabilitation, which is focused on functional goals, and CST can help maintain cognitive function and quality of life. Psychosocial support through tailored communication about diagnosis and counseling, and group-based programs can focus on cognition and well-being and are beneficial. Education is important, so topics like legal, financial, and driving are important aspects, as well as practical interventions such as occupational therapy like COPE that involve environmental assessment and modification, assistive technology, and task simplification can help to promote independence in daily activities. Other lifestyle interventions such as exercise groups, nutrition, sleep interventions can also support overall well-being. And care coordination is also important through a single point of contact who can develop a personalised care plan and link people to community services. That's also known to be quite important to people with dementia and their care partners. Importantly, all of these approaches should be person-centered and tailored to the person's preferences, skills, and abilities. So here in the ACT in 2022, we thought, what would happen if we tried to combine all of these things into one program? So SPICE stands for Sustainable Personalised Interventions for Cognition, Care, and Engagement. We did some research back in 2022 and demonstrated that here in the ACT, there's a lack of dementia-specific services. There are issues with receiving a timely diagnosis, which can then delay access to supports, a limited number of health and aged care workers who have received dementia-specific training, and a low understanding of dementia in the general public. So working with Canberra Health Services, as well as Dementia Australia advocates, we worked to develop and commence the SPICE program. It initially started as a small pilot before expanding and is currently funded through to mid-2028. And from a research perspective, we've been investigating whether the program works to help support whether SPICE can be an ongoing service here in the ACT. So it is a 12-week program, and people attend 2 afternoons per week for 2.5 hours. People with dementia receive cognitive stimulation therapy. There's exercise and care partner education. It also has the COPE program and up to 3 appointments with a dietitian. So you've already heard a lot about CST today, but it's the real centerpiece of SPICE. And because it is a 12-week program, people receive 24 sessions, which is more than the original protocol of 14 sessions. So our team has developed a few extra sessions and used the CST maintenance manual as well. At the same time, people with dementia at CST, care partners receive a series of workshops from different allied health professionals, which includes education and upskilling, but also really focuses in on stress reduction and mindfulness strategies for care partners to look after themselves. And then after afternoon tea on both days, both the person with dementia and care partner participate together in group exercise, which is a circuit-based program with 7 different stations so that each dyad can spend 5 minutes at each one. There's a high cognitive component, so including things like dual tasking, and the exercises are repeated throughout. So what we see is people with dementia improve and learn as the program goes on. This is an overview of the care partner education program, and I won't go through all of these, but you can see here in the middle in blue, that's really focused on care partner wellbeing. And we get Dementia Australia and Carers ACT in during the last week as well to do some question and answer. And here's some pictures from the exercise program. You can see here this man doing with the table tennis bat and walking through the cones. That one is much harder than it looks, and some people have been able to do it backwards by the end of the program. And in the top right, you can see everyone is playing balloon volleyball. That's a really popular part of the program on every Friday afternoon or Thursday afternoon for our other Southside group. Everyone also receives the COPE program, which you've already heard a lot about, as well as 3 appointments with a dietitian, focused on making manageable changes to their diet. Not everyone needs the full 3 appointments. It just depends on how they're going with managing their nutrition and hydration when they have that first appointment. Probably something that's really important about the SPICE program that we didn't really foresee when we came into it was just the importance of social engagement and bringing everyone together for over 60 hours and doing all of these different interventions together and just getting to know each other. So I'll go through some of our research results. The most common type of dementia in the people who've completed the program, and this is through the first phase to the end of 2024, was Alzheimer's disease. And most people were living with mild dementia. The majority of people who participated with the person with dementia was their spouse or partner. And you can see here there's quite a range of people who came through in terms of their time since diagnosis. But there is quite a long waiting list for the program, so those results are skewed a bit towards how long they're on the waiting list as well. We had really high attendance throughout the first 14 groups of the program, over 92% for both people with dementia and their care partners. And we've seen improvements across almost all of our outcome measures. The most impressive ones here are shaded in green, particularly around quality of life, as well as quality of life as reported by the care partner relating to the person with dementia. There were improvements in cognitive function pre and post program, but we didn't see that maintained through to the follow-up. And there was a reduction in neuropsychiatric symptoms as well, as reported by the care partner, as well as their distress related to those symptoms. Care partners also reported an improvement in self-efficacy in the perceived change index between pre and post program. Somewhat surprisingly, we also saw improvements in some of the physical outcome measures. So hand grip strength improved for both people with dementia and their care partners. Care partners in particular improved across almost all of those measures, except for the 10-meter walk test. And those were maintained at the 12-week follow-up as well. The program satisfaction ratings are really high, with most participants saying that they agree or strongly agree with enjoying the program, finding it to be useful and beneficial. The ratings from care partners, as you can see through the dark blue here, were particularly strong. And we've been doing a bit of qualitative research around the program as well. And we've just got some really great quotes here. So people saying that the program made them feel less lonely. It built their confidence. My favorite one here is in the bottom right. The exercise was, dare I say it, very good. I can now put my pants on without problems in the morning. And I mentioned before that just importance of being connected with other people going through the same things as you are. And what we've seen after each group that is completed, all but one group has started up their own WhatsApp chat where care partners can talk to each other and organise social gatherings. If you go to any of the Dementia Australia memory cafes here in the ACT, it'll be mostly SPICE people. And if someone comes in who hasn't done it, they usually get referred to us. Some of our groups have gone on day trips together to the coast and on country trips. And one group even started their own exercise group. And a couple of them are most of them are regularly meeting up for lunches and dinners and doing a range of different things, which has been wonderful to see. We published a paper just on some of the challenges to implementing such a complex program. I won't go through this in too much detail, but it's important to have an organization that is ready to implement something as complex as SPICE. We did have a lot of difficulties implementing it as part of an outpatient rehabilitation hospital. It really did require the collaboration between the university and Canberra Health Services. And that did take some time to sort of work that out in everyone's roles. But I don't think this would have happened if we weren't working together as a team. We did get a change in funding starting at the middle of this year. We did have to take the program down from a 12 to a 10-week program. We've consistently got North and South Side groups starting every 6 weeks. We had to increase the size of each group of SPICE to 7 to 8 dyads. And we now have a triaging process with the COPE program so that people who need it the most are getting it first. And we're making sure that we have some longer term follow-ups to measure outcome measures past a year after they've completed the program. A couple of limitations is that people who are unable to participate with a care partner can't take part in the SPICE program. It's not suitable for people who can't have transport to get to one of our 2 sites, as well as people who may not be comfortable with English or have hearing or visual problems as well. But to address this, we are starting to pilot a Spice at Home program, which is a bit shorter than the COPE program, and we primarily delivered by an allied health assistant after an occupational therapist and physiotherapist does an assessment. And everyone that goes through the Spice program says what happens next. So we have been working with Carers ACT to have a student-led 1 day per week version of Spice moving forward. And pretty soon we'll be expanding into New South Wales and hopefully elsewhere as well. So I'd just like to acknowledge all of the people who participated in the SPICE program and contributed to our research, and all of the investigators and the Canberra Health Services team that have been part of the program, and all of the funders and advisors as well. Thank you.
Wow, thank you, Nathan. And good to know that there is an intention to bring the SPICE program to other places. I'm sure we would love to see it here in WA for sure. And I just noticed, and I'm glad you addressed it in your slides, because Isabel from Alzheimer's WA put in the chat, you know, that carers reported feeling down at losing their support network. And I know firsthand how in the beginning in 2016, when 30 of us got together and did a Living with Dementia program, at the end, the reason we got together and formed our own network was for that very reason. And we now have 150 carer couples in that network. And out of those original 30, only 4 are still living. And we actually have a group called the Yottos because they're widowed and they all get together and continue to, you know, socialise and support each other. So I think that power of peer support and what you really need to keep going is so important. But I've taken up enough time. I'm going to hand over to Alan, my esteemed colleague, who's going to now manage and the questions and direct them to the panel members. So thank you all. It was just fabulous.
Yeah, thanks, Vicky. And look, thanks everyone. That was fascinating listening. It was great. Look, we've had a few questions. There's been a few more come in since you've wound up, but hopefully we'll get to those in the 15 minutes. Amanda, Shireen's had a question around whether CST was adaptable for different cultures.
Yeah, sure. I know there's research being done on this. Naomi and Nathan, feel free to jump in. There is research being done on this at the moment in the UK and in Hong Kong. It can be adapted by the person running the group. It would just depend on the cohort of people attending. It is challenging in a group situation. Certainly, individual CST can definitely be adapted. That's not a problem at all. It's just the group environment where it gets a bit more challenging. It's difficult when we have cultural situations where it's not actually okay for somebody to speak up and give opinions, because CST is all about getting people's opinions and their thoughts and things. So I think that is an area of that is being reviewed. I know New Zealand have done a big adaptation in the Māori language. I missed the meeting, but Nathan and Naomi may like to speak to this. So it definitely can be done. But I think it's not easy. It's something that needs individualised attention from the person running the program.
Yeah, there are adaptation guidelines that have been published, and like Amanda said, there have been some adaptations in New Zealand to the Maori, and other adaptations around the world. But you know, within our groups, if someone is, you know, not confident speaking English, we can't include people who don't speak English. But if they're not confident speaking English, we do find different ways to make sure that they're feeling comfortable and included, and adapting some of the different activities to them. I know there's a group and some researchers who would like to see an adaptation for young onset dementia, and we have got a grant application in at the moment, so fingers crossed for that. And I know my colleague Robin Lewis, who I think is here, would love to see a First Nations adaptation done as well. And there are guidelines around how to do this, but of course it takes time and money, and it's important to make sure that it's done right and that we include people impacted by dementia in guiding the adaptation of CST.
Thanks, Nathan. Look, we had a few sort of questions at various times through each of your presentations around whether there was sort of group that was better suited to each of the interventions, like whether young onset dementia was better for COPE or SPICE or whatever. And Nathan, there was a question in there around the mean age of the people that you evaluated in your program. So I'm just wondering whether each of you or some of you could just address that question around the suitability of each of the interventions for different ages, or whether it's just around individual tailoring.
Sure, I'll go first. So in the SPICE program, our average age is 78 through the first 14 groups, but we've had a very wide range. So we've had people in their 50s participate with young onset, and all the way up to people in their early 90s who are still living alone. And sometimes we've gone into those groups with people of different age ranges, wondering if that they would mix well. Would it all work? Would the program still happen the way it has in previous groups? And it can take a little bit of management and talking with people about their expectations, but it has worked. As with any group program that goes for 10 weeks and you're throwing everyone in together, it can take a little while for everyone to get used to each other, but this usually happens after the first, second, or third week. And we have seen some instances where people with young onset dementia take other people within the group sort of under their wing and sort of get some enrichment out of that experience as well. Because while the CST facilitators do try to adapt the different activities within the CST structure as best they can, sometimes it's not always possible, but we have seen that sort of mentorship side of it come through, which has been really nice to see.
Oh, that's good. Amanda and Naomi, have you anything to add to just around the suitability to age?
Just with the COPE program, it can be offered at any age. So I guess one consideration with younger onset dementia, which I'm sure everyone listening would understand, is that care partners may still be working. So finding times that are, compatible to their work arrangements. So with COPE, you can have some telehealth or telephone sessions, which could help if a care partner is still, trying to work as well, and having sort of sessions in the evening or at times that are suitable for them.
No worries. Thanks for that. Look, and there's another question just around, and it probably goes to running this in a group as well, where you've got people at different disease stages, and different types of expression of the disease, is how you deal with those sort of different abilities and kind of preferences and expectations in a group.
Want me to speak to that?
Yeah, go.
Look, it can be challenging, and I think a lot of it relies on the person running the group to be experienced and having understanding about how dementia is impacting the person, so that we can then support and guide that. Like I said, I think it relies on having really good quality resources. And that's one of the things I've spent the last 9 months doing, is creating really good quality therapy sessions and resources, because there's a lot of ways we can target people to be engaged and interested. If someone has visual processing difficulties, they can usually hear pretty well. So we need to make sure that our programs and our sessions and our resources are ticking as many aspects of cognitive function and engagement we can, but that's very hard to do. It's not easy to do.
Yeah, and Amanda, you were saying that you have 2 facilitators, and for a small group, so that probably helps as well when you can you can have more people sort of with eyes on how people are going in the group.
Oh, my clients get so much individualized support. But can I just speak to the other question as well about when is the best age to do CST? And CST is the evidence is for people with mild to moderate dementia. But can I just recommend that as soon as you get a diagnosis of dementia, you start thinking about things that can support your brain health, because like I said about that neuroplasticity side of things, we want to be getting the healthy brain and working that out to the best of its ability. We want to strengthen that, get that working really well. We don't want to wait until it's starting to trip up and struggle and then try and work on it. We want to get in as early as possible. So preach that to the neurologists and the doctors and every health professional you see, because we need to get.
No, that's good. Nathan, your program was obviously university led and evaluated fairly thoroughly. But I suppose, Amanda and Naomi, just the programs that you're running either with individuals or with small groups, how are they evaluated sort of at the individual level? You know, like people going away, the care partners, to sort of see what sort of impact it has in the short and longer term. Do you get much feedback, or do you seek feedback about how it's impacting on people?
In the past, when I've offered it in private practice, it's just yeah, evident in the way that the person living with dementia is able to engage, and that relationship, I think, between the care partner and the person living with dementia. So there was no formal evaluations that I did as a private practitioner, and not that we're doing at the moment in our program, but definitely something that we should be looking at and probably will look at, but also feeding back to the referral source as well. So, you know, they've made a referral at a point in time when people may be having challenges, and to be able to feedback of the changes that the family have experienced, you know, is testament to how the program has worked, I think.
Thanks.
And we do have more objective measures in the group that I run. CST does actually have outcome measures as well, where we're looking at, we grade for every session, we grade a person's engagement, how they participated, were they interested, all those sorts of things on a scale of, I'm trying to remind myself, I think it's 1 to 4. And then I also look at other things as well. So I think it's very much dependent on who's running the program. Yes.
Yep. No worries. And look, while you've got your microphone on, Amanda, Jess has got a question around, and this is probably the best one for you, being a physio, but are exercise physiologists able to run COPE or CST programs if they've done the training?
They possibly can. I feel like Robin or Naomi or Nathan would know more about this. I don't think you have to have a degree, like a health professional degree, to run CST. Is that correct, Nathan?
Yeah, that's right. So, I mean, generally, anyone can do the CST facilitator training, but it's very highly recommended that the person does have an interest and experience working with people with dementia. And the people who do come to the facilitator trainings pretty much all do. And I think what we've seen we do have our occupational therapists. They are the ones that are leading the CST program, and they also work with our people with dementia in COPE as well. So they get to see them in both environments. So therefore, when they are doing CST with them, they know a bit about their interests and their situation and their cognitive abilities from COPE, and that really helps to sort of maximize CST for them. That's something that we've noticed that has worked really well. But typically the person assisting CST in our program is an allied health assistant.
Okay. Yep. Thanks for that. And look, there was just another question that Di asked earlier on, just around the geographic availability of COPE and SPICE. SPICE is obviously you've run it in Canberra, but I think it's probably a more general question around how available these programs are, both in WA and elsewhere.
I know that the COPE training is run probably 3 or 4 times a year, and it's been running for, I don't know, 5 or 6 years now. So there are a lot of COPE trained occupational therapists. So there is a specific, doesn't have to be run, it does need to be run by an OT. But there are a lot out there. So whether they're offering it at the moment, you can go onto the COPE website and put your suburb or postcode in and find who's running it.
In terms of SPICE, yes, it's just in the ACT at the moment, but later this year we're expanding up into the Southern Highlands of New South Wales, and I'm writing a couple of grants to try and implement SPICE in rural and regional areas, and just trying to find a few partners at the moment if anyone is interested. But what I would say in terms of one of our colleagues, Isabel, does CST and then care education in Melbourne. And I think that's a model that works really well. Something that we hear a lot from care partners is, well, I can't go to this support group, or I can't go to that because what do I do with my loved one? So if you have CST and care partner education at the same time for twice a week for 7 weeks, I think that's something that's achievable and probably not as expensive as something like the SPICE program. yeah, I think more places should be considering that model.
Yep. Well, hopefully after today, I think there might be a bit of interest in the training and the expansion of availability. So thank you for that, and look, thanks everyone for those questions. I think it made for sort of to close off a few of those loose ends. So thanks very much.
So to wrap up, CST, COPE, SPICE and All Things Nice, all three of you have got an open invitation to the AWA Symposium. So I think that pretty much says it all for me. We do have CST training coming up in Perth. You will all get a flyer for that post the event with the recording, but if I can share my screen, I think here you have a QR code and the dates are the 6th of June. Oops, what's happening? And I believe that the master trainer for that, who Nathan referred to as Isabel Sanger. So I think that...
can't see your screen, Vicky. Sorry, I can't see anything. Can everyone see the screen?
Oh, it doesn't matter. You'll all get it anyway.
Okay.
Anyway, great opportunity for you all, and you'll get that information. So look, I think it's been fabulous. We've ended up with, I think, roughly about 50 participants. We had 120 registered, so interesting. And we'll look forward to seeing you all again when we host our next webinar. So we'll keep you posted on that. And thanks for joining us today. And special thanks to you, Amanda, Naomi, and Nathan. Very engaging presentations. Clearly plenty of interest and people keen to take up the training and provide the delivery of the programs. And just one thing to note, that whole thing around culturally appropriate services for cold and Aboriginal and Torres Strait Islanders, we all know that for all of these services, they are cohorts that are hard to reach and engage. And I'm certainly starting to get engaged with the Association for Culturally Appropriate Services. We're lucky to have Mary Gorgonia here in Perth, who is very a great advocate in that area and whose mum actually had dementia. So I think we've got some good contact there and we can progress some of this stuff, which is a challenge for the network in general. So thank you, everyone, and we'll see you soon again. Bye.